Ramsay Healthcare is a global provider of healthcare. We operate in 11 countries, employing 77,000 staff, and incredibly we look after over 8 million patients a year. Ramsay Healthcare has been here in the UK for the last 12 years. We've now become the #1 provider for NHS services, which means that GPs are able to choose Ramsay hospitals to refer their patients for high quality healthcare. So Ramsay has got a long-standing set of values called the Ramsay Way. They really define who we are as an organisation, how we work together, how we look after patients, and ultimately it's all about people caring for people. We're very proud of the services that we provide, and that's largely due to teamwork and our staff. The difference that this makes for patients is really high quality healthcare in all of our hospitals and facilities. We've got an absolutely fantastic programme called Speaking Up for Safety. It's all about training staff to be positive and to call out episodes in patients' care, particularly when they're concerned that things aren't going right. We've been able to grab this programme, and we're the first organisation in the UK to roll this programme out. The future for Ramsay Healthcare is bright both globally and for us here in the UK. All of our units are accredited for endoscopy. The Care Quality Commission has rated 92% of our hospitals as good, and 95% of our patients would recommend us to their friends and family. We're a leader in day case surgery. We've looked at the way that our hospitals are designed so that we can treat ever more patients in today's healthcare. The future of healthcare is all about partnerships and integrating the patient journey. At Ramsay, this means we need to be working very closely with all our partners, including the NHS, to make sure that our services are available in all the communities that our hospitals serve. Over time, I can see the company both growing and expanding in the reach of its services. But for me, most of all, patient safety and quality come first. Simply put, people caring for people.
Good evening, everyone. Welcome to our Lectures of Distinction. Tonight's speaker is Miss Nikki Kelsall, who is a foot and ankle consultant at the University of Dorset Hospitals. She has a specialist interest in diabetic feet and sports trauma. Again, a big thank you to Ramsay Health for sponsoring tonight's lectures. Please submit your questions as we go along, and I will feed them through to the speaker. Don't be shy, no questions, silly question. And in addition to that, please don't forget the feedback code will be provided in the chat. At the end, please fill them in for your CPD forms and points. Without further ado, I introduce Ms. Kelsall.
Good evening, thank you very much, and thank you very much for inviting me. I'm just going to share my screen with you now. Here we go. So this is my team down here in Dorset. So this is myself here, and Charlene's a new consultant who joined us about a year ago, perhaps a bit more now, and my two senior colleagues, Heath Taylor and Mark Farrer. So Heath is our chair of BOFAS at the moment. So we've got quite a big unit, and this is Laura, who was our registrar when this photo is taken, and she's about to come back as our fellow, which is great. So we're going to talk today about why diabetic foot disease is important, a little bit about trauma, ulcers and infection, because I know that the lecture is about Charcot, but you can't really talk about diabetic foot disease without touching on the other areas. I'll talk about a few lessons that I've learned and a few things that I think are essential in the care of diabetic foot patients. So diabetes is a huge growing problem, as I'm sure you know, and it went from, during my time training, it went from 1.9 to 2.9 million people in the country, most of that being type 2 diabetes, and they estimate that 5 million people will have diabetes by the end of 2025, which is suddenly not that far away, just 3 years, and that works out to approximately 1 in 12 of our population. So that's a huge number of people, that we look after who have the potential to then get complications from diabetes. And because of the numbers are that big, the cost of treating it is astronomical. So 10 years ago, it was 9.8 billion we spent on the care of diabetes, which is approximately 10% of the NHS budget, which, given that it's one of the illnesses that 10% of the population will have, is a huge chunk of the money that we spend. 25% of all admissions for patients with diabetes are for their feet. So we all think of the problems of diabetes and the admissions for diabetes being DKA and being very sick and having sepsis, but actually a quarter of the admissions are for a problem with their feet. So it's a huge burden on the NHS. And here in Dorset, until Charlene was employed, I was the only foot and ankle surgeon who put my hand up as a diabetic foot specialist. So it's a huge amount of work for a very small number of people. We've got one in Dorset, we've got two diabetologists that specialise in feet. We've had an opening for one for the last 5 years that we've not been able to fill. So it's a very it's a huge burden with a very few number of clinicians that look after it. So if you have diabetes, 10% of patients with diabetes will get a foot ulcer. 50% of patients with foot ulcers will have an amputation within 5 years. That's huge. That's a huge number of patients and a massive risk. And then 70% of patients who have an amputation will die within 5 years. So that's a worse prognosis than most cancers. 70% death rate at 5 years is horrendous. So if we can do anything to reduce their risk of amputation, then we are hopefully reducing their risk of dying. However, they may be dying because they've got terrible diabetes, and that may also be the reason they're having their amputation. But if a patient has an amputation, they become a lot less mobile. Their weight is likely to go up, and therefore their cardiovascular disease worsens. So although they might not be strictly linked, there is a link, and it is worth us trying to keep these legs attached. We do more than 100 amputations a week in the UK for diabetes, which is huge. And we think 80% of those are preventable. And that statistic in itself, 80% of amputations being preventable, is shameful, really, because this is people who become immobile and housebound. So it's really important that we get better at this. So the diabetic foot problems can be divided into acute or chronic, and the acute will be normal trauma in patients with diabetes or foot attack, so infection. And the chronic problems are foot ulcers with or without deformity and Charcot foot disease, which is what we'll mainly concentrate on today. And all of those things can be with or without vascular disease. Charcot is mainly without vascular disease, but the others can all be with or without. So you need to have support from your vascular team if you're looking after these patients. So I was really lucky. The NICE produced this guidance in 2015, which was the year I CCT'd. I needed a job, and suddenly my hospital where I wanted to work needed to fulfill the NICE guidance. So that was really handy. This covers all acute problems, and essentially says that care should be available to all patients across all settings within 24 hours. And that's quite difficult to achieve. We're very lucky here. We've got podiatry clinics that run 5 days a week, and patients can self-refer and access them quite quickly now. The team that look after patients with diabetic foot disease is huge, and it starts in primary care. There are the medical professionals and the allied medical professionals that work with them, and it's mostly them that do all the hard work, to be honest. It's our podiatrists that do most of the hard work, along with the plaster techs and the nurse specialists. We work very closely with our microbiologists. We have a couple of radiologists who, again, are much more used to looking at our scans than others, and a huge rehab team. And right at the heart of all this is the patient, and the patient has got to really buy into their care and their treatment in order for us to get anywhere with getting it right. So I'm not really going to cover much about infection or or chronic foot ulcers today, but just to say that with infection, it's really important that you get on top of it quickly and radically, because this is the one thing that I do in foot and ankle surgery that might be life-saving, and it can certainly be limb-saving if you get it right. The chronic foot ulcers, it's really important with them that you get the chemical environment right, so you get their diabetes under control, and the mechanical environment right. So the reason that these patients here, you see my mouse, these patients here have ulcers in the front of their foot is because they have forefoot overload. And the reason they have forefoot overload is because their Achilles tendon is too tight. So you need to lift the front of their foot off the floor by lengthening their tendon. And the most common way in diabetic patients is with this Hoke lengthening over here. And then similarly with the toes, if the toes are this shape, then they're going to get ulcers, so you need to straighten them. And that can be done classically with K-wires, or I tend to use the absorbable K-wire, which is in this picture here. I can't not mention trauma when I mention Charcot's. There'll be a little bit more trauma than the other two that I've just spoken about. So acute trauma in a patient who has poor sensation needs to be treated with more metal work, more offloading, and be really aware of the risk of infection in Charcot. So a patient who has normal sensation can be treated normally, like a patient without diabetes, just with heightened awareness of their risks, whereas a patient with poor sensation needs to be treated differently. The same with if they have poor vascularity. If you don't have blood flow going to a bone, it's not going to heal. So you need to speak to your vascular surgeons about whether they think reconstruction is appropriate or not, and as well be aware of their increased risk of infection. And checking their HbA1c as well as their blood sugars is really important. And if it's not controlled, then you need your diabetic team to come and help you control that, because sugary blood is the perfect environment for bugs to grow. So it's really important that even if they aren't controlled well in the community long term, everybody can be controlled well in the hospital short term by your diabetic specialists. So we have this proforma here down in Dorset, which we follow, which is in all three of our hospitals, Dorchester, Poole and Bournemouth. And it just reminds you to check the essential things, so their sensation and vascular supply, and if they've had previous Charcot, and just reminds you how to then treat them thereafter. And this side of the guidelines reminds you how to assess a diabetic foot, because it's not something that everybody does all of the time. So it's reasonable for us to remind people how to do it properly. So moving on really to Charcot. So it's poorly recognised, underdiagnosed and poorly managed. Because you can't manage something if you haven't recognised it or diagnosed it. And often these patients will have sought help from health professionals that will only have seen one case ever in their whole career, and they treat it as something different because they haven't seen Charcot before. So it's really important that we continue to educate people about what this is. So during today's talk, I'll talk about what it is, a little bit of history, who gets it, why, and then how we assess it and treat it. So it's a destructive skeletal process. It affects the bones and the joints. They fragment, and when they fragment, they dislocate, and when they dislocate, they become unstable. It causes deformity and bony prominences in the foot that wouldn't normally be there, like this one. This is going to be very prominent in a shoe, very hard to shoe. It's often on one side and self-limiting, but it can be on both sides, and it's not always in the same joint on both sides, which can be interesting to manage as well. So it was originally described back in the 1800s by Jean-Martin Charcot, who was a gynecologist who obviously got a bit bored and ventured a bit further down the body, and was initially described in patients with syphilis, because at that time we didn't have any way of treating diabetes, so patients with diabetes didn't live long enough to get their Charcot. The other group of patients he saw it in were patients with alcohol abuse. So it's probably less than 1% of patients with diabetes who get this. So this isn't the huge burden in terms of what we were talking about before on the NHS. in terms of numbers, but it's a huge burden in terms of their care, because they will remain under the care of the hospital for many, many months, and the surgeries that they end up having are very large rather than very small. So even though there's a small number of patients, the burden that they give us is quite large. They've normally had diabetes for more than 10 years, and we see it more in men than women. In insulin dependent, we see it in their 5th decade, and in non-insulin dependent in their 6th decade. And generally 5 to 10 years after diagnosis, but that doesn't mean 5 to 10 years after they've developed diabetes, because often they're not diagnosed with their diabetes for many years before. And sometimes Charcot can be the thing that triggers the diagnosis itself. And it's not related to the severity. So Charcot, unlike infection, isn't related to their how well controlled their sugars are. You're at increased risk with increased BMI, and that's purely a mechanical thing. And you've got more weight going through the joints, so they're more at risk of collapsing. Vascular compromise appears to be protective, because in order to get massive inflammation, you need a good blood supply. So if they've got a good blood supply, they're unlikely to have Charcot. But patients who have Charcot have a much higher mortality rate than patients who don't. So there are various different theories as to why it happens. It can be neurotraumatic or neurovascular, neurotropic. So neurotraumatic is basically cumulative trauma. So you and I, when we're walking around in shoes that don't fit us properly, we feel that, we take them off, we stretch our feet out, we change our shoes, we stop walking. And if you're not getting any of those cues to protect your feet, then you continue to walk, causing micro trauma with every step that you take. And the joints become inflamed, and then they become unstable, and then they become a bit more inflamed, and it goes in a cycle like that. And they often will be diagnosed initially as stress fractures, and these are essentially a very exaggerated stress fracture process. And the neurovascular theory is that they have abnormal vasomotor control with AV shunting, which causes increased bone resorption and therefore weakening of the tissues. And it's probably a combination of all of these things together that cause people to get severe Charcot. So the reason patients get a peripheral neuropathy is because their glucose pathway is overloaded. So the glucose should come in here and come out here. And if you've got too much glucose in there, it doesn't do that. It goes around into the sorbitol pathway. And it's this product, the sorbitol, which is damaging to the nerves. And that's interesting because lots of people who are avoiding sugar in their diet will be having lots of non-sugar sweeteners and may have an increased intake of sorbitol. So I wonder if we're going to have an epidemic of non-diabetic Charcot in 20 years' time when we've all damaged our nerves from our sweeteners. And this damage affects the whole of the nerve, so sensory and motor, as well as the autonomic changes that they get. Inflammation is also involved in this and then plays a part in the osteolysis of the bones. So once things start to collapse, then the bones start to be resorbed. And the clinical features can be very confusing for other things that diabetic patients also get. So it can be incredibly swollen or not too swollen. It will be warm, it will be a bit red, they'll have their sensory neuropathy, and they'll have a pulse. So because of that, that's why you end up often with misdiagnoses. So this patient doesn't have Charcot, this patient has a DVT, but they do have a swollen red foot with a reasonable pulse. So it's easy to see how you'd get confused. So often there'll be patients who have been treated with 1 or 2 courses of antibiotics before they see you. They'll have had DVT scans, and it's only at that point when people then start thinking, oh, none of those things, what else could it be? And it may begin with a stress fracture. So they may actually have a trauma at the beginning. So when you're assessing these patients, it's mainly clinical and through the history and finding out exactly, how they feel. They might, in terms of excluding infection, it can be really hard, because if the foot collapses and then they get an ulcer, they may also have infection. And with their blood tests, they've got severe inflammation in their foot. So you may get a rise in the inflammatory markers, even if it's not the massive rise that you'd see in sepsis. So x-rays are essential, serial x-rays, weight bearing, are essential so that you can track the progress of their disease. And MRIs can sometimes be helpful. So if you see an MRI like this one, this has a stress fracture in the calcaneum. And you'd still need to protect it and treat it, but you can be a bit happier that this is a stress fracture and not Charcot. Whereas often there'll be lots of white all around the midfoot often, and it can be very, very hard even for specialist radiologists to tell the difference between the inflammation of Charcot and the inflammation of infection, unless you have a pocket of pus, and then you can be a bit more sure that you're dealing with infection rather than Charcot. Ultrasounds can be helpful to look for collections if they can't go in the scanner, if they've got some reason why they can't go in. I don't biopsy them often, but biopsies can sometimes be helpful if you're really not sure if it's infection or not. So your x-rays are going to show you these osteolytic changes where you've got the bone being resorbed here, and they can help you with the stage, which we'll talk about because it's important for your exam, and the type, which is also important for your exams. So for me, recognising it is the most important thing, and if that's what we achieve from this lecture tonight, that somebody recognises one case of Charcot, then we've won. But for your exam, we've got to know all the details, unfortunately. So treatment for Charcot is mainly non-surgical. Most people will be treated in some form of support, whether that's a traditional TCC, including the toes or not, or one of the multiple different boots on the market. Mostly they'll be treated non-surgically. It's only later on that patients might be treated with surgery. I don't really get involved in the medical treatment, but there are options out there for treating with bisphosphonate, parathyroid and anti-TNF. And for your exam, I would know that they can be used, but I wouldn't worry too much about these sorts of flow diagrams that you can find. I think if you're getting into this level, then you're on for your 7. So we'll talk a bit more about the stages, but just to go through them briefly here. So you start with just inflammation. And when it's just inflamed, your x-rays will be normal, and that's the most difficult time to diagnose it. There are some people that will operate on these before they get hot. I've had one that I was going to operate on. I was absolutely sure what it was. 3 days later, he was way too hot for me to touch, and so we never got his operation. And then you go into stage 1, where the bones start to fragment. Then stage 2, where the smaller bits absorb and the bigger bits coalesce together, and then stage 3, where it starts to remodel and becomes cooler and stable, and it's at this point that we can then decide whether or not they need stabilizing surgery. So stage 1, this is where you get your acute inflammatory response, red hot swollen foot. You may have a normal x-ray, or you may have some bony debris and a little bit of fragmentation occurring, and this is when you start to see the subluxation and dislocations. Treatment for this, like we said before, is mainly non-surgical, and you have to keep going. You have to warn the patient that it's going to be 6 to 12 months of their life that they're going to be in a below-knee cast, and you're going to ask them to perform essential weight bearing only. Now, essential weight bearing for me is going to the toilet. Essential weight bearing for my patients is not. For them, essential weight bearing might be taking their mum to the hospital, taking their bins out, taking their dogs for a walk, taking their children to school. Lots of daily activities that they believe are essential in their life for their lives to continue, that I don't think they are, because I understand that if they load their foot, they might lose it, because that's what I see. They don't see that, and they probably don't know anybody that's had Charcot. So it's very hard to have that conversation with them, because you are taking people who were relatively well previously and making them housebound. And everybody got a bit more used to that during lockdown, but we all know how miserable it is now, so none of us want to do it at all. So we should be a bit more understanding of our patients being unable to comply with us. The other thing to think about with that is that if they're polyols have damaged their peripheral nerves enough that they can't feel their feet. They've probably also damaged their central nerves similarly. So if you think of these patients as being people with dementia who just don't really understand, you can be a lot more sympathetic and a lot more understanding when they don't follow the rules that you're setting out for them. And just every time you see them, every healthcare person that sees them, they have to give them the same message, and over again, repeating it, like, you need to offload it as much as possible, only essential stuff. Because it's really important that we maintain the shape of their foot for them so that they don't get ulcers. So stage 2 is when your x-rays start to look a bit more scary. You see absorption and the loss of arches in the foot. The fragments coalesce together and you start to see these sclerotic changes. So it's a lot whiter on this x-ray than previously. And by this point, they're less in their boots and their casts and more into bracing and custom shoes. So by stage 3, this is where you start to actually find out what residual deformity they're going to have left. The bones start to ankylose together, the edges of the bone become more rounded and smooth, the same as old fractures look. And the foot becomes cool. And it's really when the foot is cool and less than 2 degrees difference between the 2 feet that you can start thinking about intervening surgically. And if you've got a foot which is this shape on x-ray, then the bone is going to start sticking out really quite soon if you don't look after the foot well. And it's these feet that you then have to think about, am I going to do some enormous operation to this patient who's just spent 6 or 9 months in a cast already? Am I going to then do some big horrible operation to them that might cause them to lose their leg in order to get their foot a better shape? So in terms of typing, so we've talked about the stages, and now this is the type, and it's just very simply where in the foot is it. So most of what we see, type 1, 2/3 here is in the midfoot, type 2 is in the hind foot, and type 3 is in the ankle. You can get it in toes and you can get it in the upper limbs. I've never seen it in the upper limb, but you can. So the midfoot is where you get these rocker bottoms. So you go from having your arch, which is this shape, to having a foot which is upside down. And they're very at risk of getting a specific ulcer over the head of the talus and their medial arch. Hindfoot, they have it's a much wider rocker bottom. So rather than getting a single ulcer over that prominence, they're the patients that have the massive ulcers over the whole of the bottom of their foot. And they're a lot more difficult to manage. And then the ankle, they can be incredibly unstable and they take a long time. I found the ones that I've only had a few, but they've really taken a long time in their boots to have anything like a sticky, more solid ankle than my midfoot ones have. So surgical treatment. So when I started, I really enjoyed doing the big operations. I still really enjoy doing the big operations, but I do far more of the smaller ones now. So the indication for surgery is if you have ulcers, if the deformity is unbraceable, unshearable, or if they're starting to get deep infection. And you can either just remove the bump in the knowledge that you might destabilize the foot and reignite the Charcot, or you can do massive surgery to realign it all and try to give them a sensible shaped foot again, or you can do an amputation. And the conversation I often have with patients when I'm doing big surgery is I will say to them, the worst case scenario for you is that you get an infection or a non-union and you may end up with a below-knee amputation. And so I need to know that you will be better off now with an amputation than you are with the foot that you've currently got, because you're going to have to really look after it for another 6 to 12 months in order for us to come out of this with a shearable foot. And that's a pretty stark conversation to have with someone, but it focuses the mind. And if they really want their foot to be a different shape and they really think that they can care for it and they really would rather not have it the way it is, then we'll take the risk together that that's where they're going to end up. So this is an exostectomy. So essentially you go in down the side of the foot, remove really quite a lot of bone, more than you think you need to, so that they no longer have a bony prominence on the sole of the foot. And this wound that you make, even though it's a non-weight bearing area, doesn't heal in 2 to 3 weeks like you tell them. It heals in some months. They take a long time. And it's just really important that even though it's the smaller of the operations, that you warn them that that's going to be the case. And then you can talk about realigning and stabilizing the foot. So this is not a case that was done by me, but this is nowhere near enough metalwork. It's really hard, I find, to achieve the right shape and a rigid fixation. And most of them, even if they do get a rigid fixation, haven't gone on to bony union. They've gone on to a fibrous union, but they are quite happy with that. So that's fine. So this is one of my cases. So this is a chap who had midfoot Charcot, and I used the salvation system. So I did calcaneal osteotomy to bring his heel back under where it should be, and fused his midfoot using the beams and also the place on the top. So this sort of surgery takes 3 hours plus to do, and then they need to be offloading for many months afterwards. And a lot of them, the beams fail here, just where the threads start, but they seem to do well even though the beams fail. And then this would be what you would do for ankle. And you can do, it doesn't really matter what you use, whether you use a nail or the, so I like the Arthrex plating system personally, because if I've got the whole ankle open, I just put a plate on rather than opening it again and putting a nail in. But yeah, and it doesn't really matter what you use to fix it, as long as it's a lot of metal and very stable. I don't do frames, but I do have a local centre that does. So if I'm worried about the skin more, then I'll send them up there to have the frames done. So the union rate is about 70%, and about 80% of them get a shoeable or braceable foot, and they're quite happy with that. And the reason they fail is because of deep infection, and if they have an unstable non-union. So if your metal fails before it's stable enough that their fibrous union is strong enough. So amputations in diabetic patients have a really poor outcome. They don't mobilize afterwards. You know, these are elderly, overweight patients generally who are really deconditioned already, and so they don't walk well afterwards. So it's not the same as a young trauma patient. There's it takes about 20% more energy to walk without one foot, and about 60%, I think, to walk without two. And you know, if you take one away, their other one is more at risk because they're putting more weight through that one. If you do it, it's really important that you optimize the length of your stump so that they can get a good functioning prosthesis afterwards. Yeah, so this is what the diabetic amputee looks like. They don't look like this. You know, they're a very different group. So I'm living the dream down in Dorset. I've now got weekly MDT. Been fighting for it for 5 years and just got it, having once a month before now. It is recognised in my job plan, and that's mostly because nobody else wants to do it, so they're quite happy to pay me to do it. I do get some very cool kit to play with. So the salvation set and the hindfoot plating sets that are really good fun kit to use if you're into operating, which is good. I think because I'm the first person that put my hand up to do it, the medics quite like me, which is nice. It's good to have orthopods out there that the medics approve of. And my colleagues think I'm a complete mug, but that's fine. I don't mind. I think education is the most important thing, and it's the COVID has really put a stop to that. But one of the big things that I did was I visited lots of the GP practices to do teaching, because I think it's really important that it's recognised early. And actually, it's the small procedures I do, so the really easy small procedures like flexor tenotomies and Achilles tendon lengthenings that make the biggest difference for my patients, not the big fun surgery, sadly. And the big fun surgery gives me lots of sleep loss. So patience is a virtue. You get to know these patients really, really well. I see them more than I see my mates. You see them every week, you know, their whole life stories and everything that's going on with their families. And it takes a long time to get them somewhere where they're functioning better. So you really do. This is, you know, I chose orthopedics because I didn't want to do cancer. I didn't want to have that sort of relationship with my patients, and yet I've chosen the subspecialty where I get exactly that relationship. We talked about diabetic dementia already. I get really disinhibited emails, so I get photographs of the most disgusting feet sent to me with no warning, and they open them over lunch. And you know, that's even some of my colleagues can't quite cope with that. And I've come to love the smell of Tink Bends, which makes the smell of diabetic feet an awful lot better. I've also got a lot better at saying no recently. Just because I do diabetic foot disease doesn't mean I do all infection in all bits of the body. So I've got a lot better at saying no. So for me, the essential things are my team and support from my team. You must have time, and you have to be very patient with how long things take and with your patients. It's taught me humility. The cases I've done that I thought were done really well are the ones that haven't necessarily done so well. And you have to be very realistic with your patients about what you can achieve for them. You must have a thermometer. I've lost mine. It's a disaster. Cerament is something that's made a big difference to my practice. I use it in almost all of my diabetic foot patients. I love a Trimit pin. They don't work quite the way they said they would, but they make a big difference for me with my patients, I think. I don't have to worry about whether or not they're looking after the pins sticking out of their toes, because they're not sticking out. And you need some sort of recon set, and be prepared for ridiculous arguments. So I had a massive argument over whether or not I was allowed to put patients straight into a boot rather than a plaster in theatre, because nobody wanted to pay that £10 for a £10 boot. So that's a whistle-stop tour through Charcot. I don't know if anyone's got any questions for me now, or if they'd like to wait until after the couple of cases that I've got to talk through.
I think there are no questions. We'll move on to the cases, and then we can do the questions after the cases.
Okay. So I've only got a couple because they're both quite long. So this lady I met when I was a locum consultant, I think 2 or 3 weeks into my job. She is in her late 40s now, so she was in her early 40s when I met her. She has diabetes. She had an ulcer on the sole of her foot. She has lymphoma, which she couldn't have her chemo for until the foot was no longer infected. She continues to smoke. She drinks. She's got spinal problems. Her husband has left her, but comes around with a packet of cigarettes every now and then just to keep her happy. And she's living with her dad, who has dementia, who tells her off if she elevates the foot for too long. So just a disaster. And what she needed was an amputation of her foot. But what she absolutely wasn't going to have was anyone cut her foot off. So we treated her with antibiotics for a bit, and then her foot did this, and you can see the difference in size. You know, it's become massive, and it's now full of pus. And this is her. You've seen these pictures before on the previous slide. So yeah, this is where we started. So I hadn't used Cerament before with her, so I said to her, look, I have no idea if this is going to work or not, but we'll have a go. So so you can see here that this is most of her midfoot is gone, and these are DHS pins that are going up through her metatarsals into some bone in her hindfoot, mostly in the calcaneum, but just anywhere really. Then filled the cavity with Cerament in the hope that it would cure the infection and give her some source of stability in her foot. I never expected her to grow a new bone out of it. And this was 6 weeks later. So, you know, when I saw her at this point, so we took the DHS pins out just in clinic because she's got no sensation. So we just removed those in clinic. And yeah, so this is at 6 weeks. So the ulcer's almost completely healed, and we were congratulating ourselves for how amazing that was. And this is the wound that we went in through, and this I think is at a year. And although her ulcer went down to pinprick size after 3 months. It took, I think, 18 months for the lateral wound to heal. And she can walk on it in a boot still, and she has had her chemotherapy, which has been unsuccessful, and it's recurred, and she's now having some other treatment. But it was definitely, for me, that was definitely a heroic operation, which was probably not the right thing for the patient. She would have had a 14-day recovery from an amputation rather than an 18-month recovery. So I think, and I said to her, "Oh, take the wound on the side of your foot will be really easy to heal compared with the one underneath," and yeah, it just isn't. And these are her most recent x-rays. So yeah, this is what she walks on now. Yes, it's not really very foot shaped on the inside, and on the outside it's a bit more foot shaped than it was, but and it's uncomfortable, but she doesn't require painkillers for it. So, success maybe. And then I don't know if anyone wants to ask questions about that one now, or has any comments or suggestions on what they might have done.
Sorry, we do have a couple of questions,
Okay.
which are probably worth touching upon. So one of the questions from Mr. Gadgill is, how do you decide when to start weight bearing the patient? And just to expand on that, it's probably worth in the trauma setting, as in the ankle, your Charcot reconstructions, and the patients that you're managing in a total contact cast. So 3 different scenarios. Any?
So for trauma, so if they've got normal sensation, then I'll weight bear them the same as any other patient. And my practice there has changed over the years. So I used to make all patients non-weight bearing for 6 weeks, and now I let them weight bear at 2. I know lots of people will weight bear people sooner than that. I go for 2 weeks because I want the wound to be healed before I let them walk around and stress the wound. So for trauma, if they've got normal sensation, I weight bear them at 2 weeks. If they've got abnormal sensation, I tell them that they can put their foot to the floor in their boots with their crutches, because they're going to do that anyway. They're not going to be completely non-weight bearing, and I'd rather them do that safely and stably and not fall over than not do it at all. And we all know that you need a bit of force going through your bones to stimulate bone healing. So I want them to do a bit, but I don't want them to partially weight bear like a patient with sensation would, because they don't know when to stop. So that's trauma. For Charcot reconstruction, it's really difficult. So I'd like to trust them enough to let them do a bit of touch weight bearing on it, but I don't. So, and I think if you say you can touch weight bear, then they fully weight bear. So I tell them that I want them to be non-weight bearing, knowing that they're not going to do that, but hoping that if I tell them to be non-weight bearing, they might be touch weight bearing, if that makes sense. And I had a woman who I must have seen her a dozen times before I did her surgery. I delayed it and I got a million different scans, and I wanted to meet her lots of times and reiterate how important it was afterwards that she took care of her foot. And she was really, really sensible, and I had a really sensible conversation every time I saw her. And she came into her 6-week appointment having put herself back into her custom shoes and without her frame. And she was like, "It feels fine. I've just put my shoes on." It's like, so I think with my Charcot reconstructions, I tell them it's going to be 3 months of non-weight bearing, knowing that they're not really going to do that.
True test of stability.
Yeah. Yeah.
Okay. And with patients with total contact casts for your ulcers, do you allow them to weight bear? Do you not?
So for ulcers, well, we tell them that they need to offload it as much as possible. So we tell them essential weight bearing only, and a few where it's a disaster and you bring them in and make them sit in their beds, then that's probably the best lesson, because then they see them improve when they're not allowed to move. But you can't send patients home and expect them to be non-weight bearing. They just can't do it.
Yeah, and for our audience, when you say essential, what's that for you?
Well, as a doctor, essential is going to the bathroom and back and feeding yourself. But as a patient, it's not. And you have to kind of explain to them that they need to get other processes in place, and they need to have their food delivered, and they need to be ordering things that doesn't require them to stand up and chop it for an hour before they can cook it. And you need to really talk them through each and every step, because unless you've been very specific with them about how to deal with everything in their life, they don't find the solutions. They want to be normal. Everybody wants to be normal. Nobody wants to be a patient. That's, even if you don't have diabetes, no one wants to be a patient.
Yeah. Okay. And second question from Nick is patients with neuropathy. Do you do your flexor tenotomies and HOPE procedures in clinic, or do you take them to theatre to do that?
So mostly they come to theatre, and that's mostly because my clinics were so horrific that if I tried to do them in clinic, I would be there for 3 hours after the clinic was supposed to finish. So it was more an organisational thing than anything else. But having said that, I did tenotomy in clinic yesterday, because I now know that if I put them on the waiting list, they're going to wait for 9 months. So I'm kind of moving my practice a bit to accommodate the new waiting times.
Okay.
But yeah, there's no reason, as long as you've got a clean area that you can use, and in clinic, then you can just crack on and do it in clinic.
Thank you. Shall we go to the next case?
Yeah. So this young man, here we are. So he sustained this minimally displaced injury, and was treated conservatively because he had peripheral neuropathy. He doesn't smoke. No, he doesn't smoke. And he didn't have a lot of pain from it, and he was kind of quite happy. He didn't really want an operation, and so that's how he was treated. It went on to a non-union. So I used this plate for the first time. So this is one of the striker plates that's got the compression screw across it, and I used Cerament, and I did a primary fusion of the tailor-navicular joint, and underneath it, so the fragment of bone is sort of on the top here. So there was a split in the navicular, as well as a fragment off the dorsum of it, and it all came back together beautifully. And I looked at this X-ray at the end, and I thought, well, that screw is a little bit on the long side. I might have to take the plate out, but that looks healed already. I'm so impressed with myself, and the plate was just perfect, and it fitted, and it was just brilliant. And it did this. So then everything fell apart. So it didn't unite. The fracture didn't unite. He went on to develop Charcot, and then he got all sorts of weird lesions in his leg. So I delayed him, and we tried Exogen, and we tried high dose vitamin D, and everything. I'd really tried very hard not to operate on this guy again, but he was in loads of pain. So he was one of the first cases when we opened up from the pandemic in the summer last year that I did, and I did it with my colleague Heath Taylor, because it's like, we haven't done any major surgery for a long time, let's do it together. So we did this, and again we congratulated ourselves on how nice it looked and how well we'd restored the anatomy, and we really went to town preparing every one of the joints on the way down, and put loads of Cerament in, and yeah, we thought we'd done really well. And then this is his X-ray from 10 days ago, from when he came to see my registrar in clinic, and he's just had a CT yesterday, which I saw today, and none of it's united. So yeah, it doesn't matter how good your surgery is, it doesn't always work out. So there's my confessions at the end.
I think, as you highlighted earlier, it's very humbling surgery. You do your best for the patients, and sometimes things don't quite go the way you want them to. And so what's your plan with this chap then? Would you just continue? I presume he's weight bearing?
Yeah, so his surgery was back in May. So I think he's been weight bearing since probably October time, and yeah, so I haven't seen him, so I haven't seen the foot. I don't know what the foot's looking like, but I think I'll just let him carry on for now, and I might talk him into Exgen again. Why not? It's a way of filling time, even if it's whether or not it actually works. It gives people something to do and some hope for 6 months.
Okay. So a couple of more questions have come in. One of the things I know you specifically didn't go into detail with was infections,
Yeah.
but for a lot of the registrars, might be worthwhile, sort of for someone with a specialist interest, when you do your debridements, what should they be doing? Do you have any tips, any key pointers to kind of give our patients the best outcomes, or the diabetic patients the best outcomes?
Yeah, so just take anything that isn't okay. Always take more than you think you need to, because you're saving their life. And I think that's the first. If they're in with a diabetic foot attack and they're septic and they've got a foot full of pus, your primary aim is to save their life, and it doesn't matter what shape foot they end up with in the end, because we'll do something to it to make it more usable than it is. But it's more usable if it's attached than if it has to be amputated. So really wash it out very thoroughly. Take more tissue than you think you need to, and if you're going through the metatarsals, you can stick cerament down into the metatarsals. You do little drill holes into the metatarsals, fill it with the cerament so that they have 40 days worth of antibiotics going into the bones. I tend to do 2-stage. I'll wash it out, leave it open. I don't overpack it. If you overpack a diabetic wound, you're never going to close it ever again. But a little bit of packing in as a wick, rather than, you don't want to stuff it full and stuff it open, because you never get the edges back together again. I do occasionally use backs on them. My tissue viability nurses hate me for it, but I do occasionally do it. Vascular surgeons close them all primarily here. They tend to do 1-stage, take loads of whatever tissue, close it primarily, and they really don't care about the biomechanics of the foot afterwards. They just take as much as you need to take to get rid of the infection. I think they're a bit better at that than orthopods are, because we look at what they're going to be left with and worry about how they're going to walk, whereas the vascular surgeons worry about keeping them alive.
Okay, so key messages are, if it's dead, take it out, be aggressive.
Yeah,
Okay.
Definitely. Yeah.
Fine. So a question from Hannah, I suppose I'm just expounding on what she's asked. She goes, when you correct a deformity, so for example, doing an exostectomy in one bit of the foot, how is there a way of predicting whether you can cause further instability? And I guess one of her following question is correcting deformity, for example, I guess the price of corrections. And she's asked specifically about correcting claw toes. Can these go on and create problems elsewhere, such as the MTP joints? So I guess two bits to that question.
So with correcting claw toes, so mostly what I do for claw toes is the flexus notomies. Mostly, I don't try and get them normal anatomy. I try to get them anatomy which isn't going to ulcerate. That's my prime aim, is to do that. So often I'm happy just with stenotomies, and the patients are really happy with stenotomies, unless the reason they're clawing is because they're gripping the floor with their, I can't see my hand. If they're gripping the floor with their toes, then I've got one patient who I've made unstable because they can no longer grip the floor. So they don't really get problems with the adjacent joint. It's more that they get problems with their stability. And with fusing toes, so with the trimmet pins, they're a bit more flexible than a K-wire, and so they bend a bit. And if you haven't done a flexus notomy as well, then they end up with slight flexion of the toes, not as flexed as they were before, but just a little bit. But actually, we're supposed to aim for, even when we fuse them straight, we're supposed to aim for about 15 degrees of flexion to make them more anatomical. So they end up with quite a nice normal looking toe. But they're supposed to absorb after 10 months, but I think they the studies were done in patients with normal blood flow, and diabetic patients don't have normal blood flow. So I've had a few work their way out after 18 months, but you can again just put them out in clinic once you kind of feel, almost feels like a bit of callus on the tip of the toe, and you just catch hold of it and pull it out.
And
that was the shape of the toes. What was the first half of the question again?
the exostectomy precipitating more instability, is there a way of predicting, or do you have any tips regarding that?
I don't know really. I don't think I've had any that I've destabilized. Not that I'm aware of anyway. I think I'm less aggressive than my colleagues. I think. I tend to, take some and then feel it from the outside, and if I can still feel any prominence, then I take a bit more. I guess as I get a bit more grown up, I might take it all in one go. I don't do minimally invasive. I've been on the course, and then COVID happened, and they didn't bring the patients in. But I think there's a real role for minimally invasive for taking the exostoses off, and for doing calcaneal osteotomies in diabetic patients. I don't really think you need it in the toes. I think we do very minimally invasive stuff already, but I think for exostoses and calcaneals, it's probably worth exploring further.
And just our last question before we conclude tonight. With regards to your experience with CERAMENT and using the vancomycin and the gentamicin, which is they're pre-packed, have you ever used them in combination, mixed the CERAMENT V and G?
No, I haven't actually. No. So to begin with, it was that I had to have massive arguments to get CERAMENT at all, and threatened to resign and all that kind of stuff. And then the rep managed to get it paid for by the CCG. So I think it caused so many fights just using it at the beginning. I think the chances of me using 2 in one patient would probably send everybody over the edge. But no, I don't know. Are other people combining the 2?
I think I've come across maybe 1 or 2. I guess part of it is what your microbiology comes back with. But do you feel there's any role, or why the preference of CERAMENT over other agents such as Stimulan, where you can choose antibiotics that you can put in?
I think when I started, it was the only one that was on license. So that was the one that I asked for, because I could justify that. The other thing that I did before they let me have CERAMENT was I used to dip all my metalwork in vancomycin powder. So if you just sprinkle vancomycin in like fairy dust at the end, it probably stays in the tissues for 2 or 3 days max. So it probably doesn't do an awful lot if you just put it directly into the soft tissues. But I used to dip my screws in the powder and then put the screws into the bone in the hope that I was kind of delivering vancomycin deep inside. But there's absolutely no evidence behind that, but it made me feel good.
I think I share a similar practice with my trauma patients, and the long cases with the magic powder is what I call it. Right.
I call it fairy dust, and my colleague calls it crystal meth. I think that says more about him than me.
Probably watched too much Breaking Bad.
Yeah.
Right, ladies and gentlemen, thank you very much for participating, and a big thank you to Miss Nikki Kelsall for this wonderful talk on Charcot, the principles of management, diagnosing it, and the consequences of major limb amputation. We'd also like to thank Ramsay Health for sponsoring this talk. Could I please encourage you to leave your feedback? This is necessary for you to acquire your forms and your CPD points. And just a reminder, next week's talk on the 15th of February will be by Mr. Nick Cullen with tendon transfers within the foot. Good evening, everyone. Take care and goodbye.
Bye-bye.
Thanks again.
My name is Andy Jones. I'm the CEO of Ramsay here in the UK. Ramsay Healthcare is a global provider of healthcare. We operate in 11 countries, employing 77,000 staff, and incredibly, we look after over 8 million patients a year. Ramsay Healthcare has been here in the UK for the last 12 years. We've now become the #1 provider for NHS services, which means that GPs are able to choose Ramsay hospitals to refer their patients for high quality healthcare. So Ramsay has got a long-standing set of values called the Ramsay Way. They really define who we are as an organisation, how we work together, how we look after patients, and ultimately it's all about people caring for people. We're very proud of the services that we provide, and that's largely due to teamwork and our staff. The difference that this makes for patients is really high quality healthcare in all of our hospitals and facilities. We've got an absolutely fantastic programme called Speaking Up for Safety. It's all about training staff to be positive and to call out episodes in patients' care, particularly when they're concerned that things aren't going right. We've been able to grab this programme, and we're the first organisation in the UK to roll this programme out. The future for Ramsay Healthcare is bright both globally and for us here in the UK. All of our units are accredited for endoscopy. The Care Quality Commission has rated 92% of our hospitals as good, and 95% of our patients would recommend us to their friends and family. We're a leader in day case surgery. We've looked at the way that our hospitals are designed so that we can treat ever more patients in today's healthcare. The future of healthcare is all about partnerships and integrating the patient journey. At Ramsay, this means we need to be working very closely with all our partners, including the NHS, to make sure that our services are available in all the communities that our hospitals serve. Over time, I can see the company both growing and expanding in the reach of its services. But for me, most of all, patient safety and quality come first. Simply put, people caring for people.